All right. Welcome, everybody.
Directly into the close to your mouth. Okay.
So my name's Jim, and I'm a pharmacist, and I'm a community liaison with Thera. Thera is this tiny little pharma company, HIV pharmaceutical company out of Montreal, Canada. Most of y'all probably never heard of us. We actually have 2 drugs in HIV. I live in Houston, cover the southern half of the United States. So tonight's conversation, maybe a little basic for everybody, but it's a conversation about treatment, resistance, and unmet need in our community. To get us started, poll the audience. What do y'all think the average suppression rate is across the country? One of these numbers here, 80, 83, 87, 90, 93%. 83, anybody else? 80. I wish it was 90. That's the goal, right? But 87, which is huge. I mean, it came up from 83 to 87 in just 2 years. And if you think back, that meant just a few years ago, we were not in the 80s. And you know, there are some clinics even who would report their suppression rates even down in the 67, 70%. So 87 is a huge improvement. But how's that track? How's that track looking at our goals for the global effort to end the epidemic? Knowing we want 90% of people diagnosed, so 90% of people that know their status. Of those, 90% of them actually linked into care. And of those that are linked to care, 90% suppressed. So we're on track for suppression, but we have to think about the fact that if 87% are suppressed, that means 13% of people in care are not undetectable. And that's what we're really going to talk about, is that's the unmet need. Because those patients with detectable viral loads, it leaves them vulnerable to developing resistance, vulnerable to disease progression, vulnerable to stigma, treatment failure, loss of options. And we know the hallmark campaign of HIV, undetectable is untransmittable. And we all know this. We all know this is based in the science that looked at 1,000 discordant couples living with HIV, one living with HIV, one not. And as long as everyone living with HIV remained undetectable, nobody transmitted virus. They didn't use condoms. They didn't use anything else. So we know the science tells us undetectable is untransmittable. But to put it in context and look at the numbers, 1.2 million in the US that are living with HIV. 1 million know their status. We're on track. That's about 87, 88%. Only 700,000 linked to care. 300,000 people that actually know their diagnosis for whatever reason are not accessing care, whether that's social determinants of health, whether they don't have access to a clinic, whether they have chosen not to get treated, or whether they just don't know where to go. 300,000 people that know their status that are not receiving care. Of the 700,000, 90,000, at 87%, 90,000 that are in care and on medication and not undetectable. Of those 90,000, 12,000 of them have multi-drug resistant virus. 1% of the HIV population in general. 13% of those with detectable viral loads have multi-drug resistant virus. Those are the patients who continue to need new options. Going back to U equals U, thinking about those 90,000 are vulnerable, like I mentioned before. Vulnerable to progression, vulnerable to stigma, vulnerable to loss of options. So the next part, we talk about why do regimens fail? And this is one of my favorite topics to get into, because if you talk with the providers, it's always the same answer. Talk to the providers and say, why do you think the patients are not undetectable? They give you one answer. They say they're not taking the medication. But that's not always the case. So we put it in buckets for why these regimens may fail, why these patients may not be undetectable. First are drug-related reasons. It may be something in the patient's genetic makeup where something just does not allow them to get to undetectable. It may be drug-drug interactions, maybe even prescription errors. So drug interactions happen, particularly when you're taking medication, say, to treat Hep C and treat HIV at the same time. There's a ton of drug interactions. And treatment history. We know that treatment history impacts the drug's ability to get us undetectable. And then there are virus-related factors. Whether the patient's got transmitted or acquired resistance, previous treatment failures, and how high is that viral load when we start this regimen, because we know it's more difficult for us to get somebody undetectable when they start with a viral load of 1 million than when their viral load is 30,000. And that last bucket, adherence related. I always say if they're not taking their medication, there's a reason. Something got in the way. Life happens, and we understand that people are going to miss doses, but we have to think about what it is that's getting in the way, because we have resources to address everything that we've got going on. So it could be other health conditions. Maybe the HIV is just not the priority. Maybe they're more worried about their oncology treatments, something else. It could be unstable housing. Housing is the biggest need we've got in the HIV community. Side effects and tolerability. We've come a long way with advances in medications. 1 pill once a day, a lot less side effects, but they still have side effects. Y'all know how it is. You go to Walgreens, get that prescription, they print out all those side effects, staple them on the bag. I know y'all don't read them. Everybody takes that thing and they throw it in the trash on their way back to their car. If y'all were like my mom, she would call me as soon as she got that prescription. She said, "Baby, this is my tongue's going to turn black." The thing is, though, those side effects happen to somebody. That's why they're reported. They happen. And side effects still happen. They're just different side effects. They're different than what treatment was in the 80s and the 90s. So probably the biggest side effect we see today is weight gain. And it's not a conversation that people are having. Drug interruption. Drug interruption happens all the time. Mail order doesn't get there. Maybe we get to the pharmacy, the copay card is expired. The pharmacy's not going to sell us that for $5 without that copay card. Or the complexity of a regimen. We know that literally just moving from once a day to twice a day doubles the chance that we're going to miss doses. And not everybody's able to be maintained on a once a day regimen. So we have to think about that. And what's that regimen look like, and how complicated is it, and does it fit their life? And I think we're fortunate today that we've got different options.
You're missing one. Now,
That's a whole nother topic. Meth is such a problem. And I don't know when that happened.
when here for one.
It is in Houston too. And I tell you, the first time I came to Palm Springs, I was sitting in my hotel and looked out the window and watched the meth heads walk by on the sidewalk. And I was like, dear Lord in heaven. All right, adherence. I could talk about this slide all day. This is a pharmacist's dream slide. So this is what I want you to take away from this. This is why the adherence lecture has always been such a lecture. Look at the black line across there. That black line is the amount of drug in the body that's needed to maintain viral suppression. You got to keep the amount of drug above that line in order to keep the virus from making copies. So you see over here, patient takes first dose, drug gets absorbed, that blue line goes up. 12 hours later, whatever the time frame is, at some point he maximizes his blood level in his body, and it'll start to be eliminated. And it gets eliminated and the blood level comes down until it's time to take that next dose. Takes dose number 2, drug gets absorbed, blood level goes back up. Gets over here, something happened. Dose number 3 didn't happen on time. This is the same story, whether it's once a day, whether it's twice a day, whether it's every 2 months. The amount of drug has got to stay above that line, because the minute that it falls below that line, the virus knows it's got that opportunity. There's a chance for it to multiply. There's a chance for it to change, to mutate. It'll find a way around the medication. That's when it causes a problem. That can happen with missed dose. It can happen if we don't take it with food, empty stomach, don't pay attention to that grapefruit juice sticker. All those stickers are there for a reason. If it says take it with food or milk, that's for one of two reasons. Either food or milk is going to keep you from having an upset stomach, or taking it with food is required for it to be absorbed. So all those little stickers mean something on there. So if we don't pay attention to that, look, and I'm guilty as anybody else. I don't look at it. I put everything in a pill box. I don't look at those stickers. I'm the worst patient. I can't even finish a Z-Pack without missing a dose. But the other thing is drug interactions. Drug interactions happen. That's why it's best to keep one pharmacist. The computer systems have gotten better. Now they will flag something that you're on, even if you took it from a mail order, the system's going to flag it. But it doesn't take into account like over-the-counter stuff. It doesn't take into account vitamins, minerals, and supplements. And some of those are problems, like St. John's wort that was wildly popular for depression for years. It interferes with everything. So we have to think about that stuff, which is all in those papers that y'all don't read. So that's the window. That's when resistance can happen. So you're familiar with this terminology. Not everybody's experience taking medications are the same. It's actually something I was going to ask about the clinical trial. A lot of the clinical trials have some restrictions. Sometimes you need to be treatment naive, which means you've never taken medication. So usually that's somebody newly diagnosed or somebody who just has not decided to take medication. So that means treatment experience. It just means that somebody's had experience taking medication for their HIV. And then heavily or highly treatment experience means they've taken multiple regimens. So usually we group that long-term survivor group in that class, but it just means they've taken multiple regimens. I'm thinking about viral load and the reasons those patients aren't undetectable. Sometimes we have it in numbers. Sometimes we get told we're undetectable, or you just have low-level virus and low-level viremia. Undetectable typically means less than 50 copies. Most doctors' offices today use a test that's more sensitive and undetectable less than 20 copies, but I think the guidelines still reference 50. It's just a matter of which test they order. The test for 50 copies is cheaper than the test for less than 20. So the number to pay attention to, though, is when that viral load gets over 200 and it stays over 200. Pops up and goes back down, not a big deal. That's a blip, and blips happen. But if it stays up over 200 and stays there, that tells us medication's not controlling the virus, and we need to figure out why. We need to ask questions. It could be missed doses. It could be resistance. It could be a lot of things. So we just have to ask the questions. So y'all seen this dozens of times in thinking about the life cycle. Multiple steps. Every step in this life cycle is a place for us to look for new medications and new ways to stop this virus from making copies. First step, the binding infusion, that's entry inhibitor class. So anything that stops the virus from actually attaching and entering the T cell. After that, the step called reverse transcription. That's because the virus is an RNA virus. Y'all know our bodies are made up of DNA. The virus knows in order to survive, it needs to change itself to DNA. So there are enzymes that work right there. The nukes, the non-nukes work in that step. After that, once it gets converted to DNA, there's an enzyme called integrase that takes that DNA material and it puts it into the body and it incorporates it into the nucleus of the cell. So the integrase inhibitors block that enzyme, they stop that process. That's probably the most powerful drug we've had for years, the integrase inhibitors that stop that step. After that, once it's incorporated into the nucleus of the cell and it's in our DNA, the virus will make copies. Makes a long strand that gets cut into active viral particles. and then they pop out and they go out and infect new T cells. So every single step, we look for medication and a way to stop that process. So reasons we change medications, usually detectable viral load, treatment failure caused by resistance or caused by difficulty taking that regimen. Especially, back in the 90s when we took 18, 20 pills a day, 3 different prescriptions with all those awful side effects. Sometimes it's just because of the side effects we change medications, not as often, but it happens. And sometimes, particularly now, we change because of convenience. Easier dosing, taking fewer pills, switching from daily pills to long-acting regimens, to injections, infusions, things that don't have to take a pill every day. So we've got options now. Let's change the conversation. Resistance to medications, the resistance just means the drug's not effective anymore because the virus mutates. It changes itself, it changes its shape, it changes something in its structure that changes the way it works, that will cause the medication to not be effective anymore. Those changes lead to resistance, elimination of options. Resistance causes our treatments to fail. We know that when the viral load goes up and stays up. Two different types of resistance. Typically, most resistance is acquired resistance, which means it happens in our body over the course of time while we're taking medication. But we can also have transmitted resistance, where the virus came to us with resistance already. So that happens probably about 20% of the time, actually. I think it's like 17. So usually somebody newly diagnosed, they'll run a resistance test as soon as they start you on medication, just to make sure that you don't have transmitted resistance or that your regimen will be effective for you. Then we run a resistance test also anytime that we're going to change medication. Those resistance tests, different types of resistance tests. Genotype resistance test will map out your virus. It literally takes your specific virus, maps it out, and looks for those changes compared to wild type virus. And that genotype test gives us back a report. Now, the report lists 3 different groups of drugs. It won't work for your virus, and it's going to list a group of drugs that they partially work. Phenotypic test does the same thing, but they take the virus and they check it against each one of the drugs. And it gives you back a same report that says this list of drugs will work, this list of drugs won't work, and this list of drugs will partially work. And then the proviral DNA test is also called the archive DNA test. It looks in the memory of the virus and looks for the history of changes because the virus remembers. So if the virus mutated, if the virus adapted itself to become resistant to medication, it puts that mutation away when it doesn't need it. But it will remember it and it'll bring it back if we were to ever reintroduce that medication again. So a bunch of different tests, they look at the virus in different ways, different lenses, but all of that is designed to guide us when we change medications, because we want to pick those drugs from the list of drugs that are fully active. That's what's most important. Because if a drug's not going to work for us, then we know we don't want to use it. Multi-drug resistant virus. 12,000 people in care taking medication that have a multi-drug resistant virus. Multi-drug resistance just means they have at least one mutation in each of 3 classes of those medications. So thinking about the pill chart, thinking about the life cycle of the virus, mutations in 3 sections, in 3 different mechanisms. And there are some patients that are taking medication that literally are resistant to everything that's on that chart today. So there's continued need for new treatment options, which is why I'm so glad you're here talking about research today. Because there's a lot in the pipeline, and we don't hear the noise we used to hear about it. Antibodies, there's a lot of antibodies, long-acting agents. There's going to be a shift where I think in the future we're going to have a lot of options. Y'all know that currently there are at least 3 medications that are approved specifically for highly treatment experienced patients with multi-drug resistant virus. 3 drugs specifically indicated for multi-drug resistant virus. We didn't used to have any. Now we got 3 that's the only patients they studied them in. Where do we find those patients with resistant virus? Anywhere. They can be anybody in that clinic. Patients who have struggled with their side effects, they're going to miss doses. They're going to struggle to maintain a blood level. Previous treatment failures, we know that first regimen is the one that's going to last the longest. Patients treated in the 90s and before, because we know medications didn't work back then. And those who struggle with adherence, for whatever reason, they struggle with adherence, they're not going to maintain blood levels. And another group that's often forgot about in long-term survivor patients is those that are vertically transmitted, the perinatally infected group. Medications for kids are so nasty and toxic and hard to tolerate. It's really hard for us to maintain a blood level. You think the pills are bad, the liquids were way worse. And they develop a whole lot of resistance before they can even walk. Then they get to be teenagers, and teens are going to do what teenagers do. They miss doses. Sometimes I've had clinics tell me they have patients whose parents have never told them why they're taking medication. So they don't know. They're not taking they're missing doses. They're not taking that medication. Then they get to adult clinic. They transfer to adult clinic about 23 years old. They come to adult clinic with all the resistance to somebody who's been living with HIV since 90s. So it happens all the time. So when we find these patients with a lot of resistance, what does the guidelines tell us to do? First up, they tell us continuing to leave somebody on a failing regimen is doing them harm, because they will continue to accumulate additional resistance. So we need to change their regimen and change it as soon as possible. So those patients, the 90,000 patients that are not undetectable, we have to address those. And when we do, we need to use those resistance tests to pick a regimen that's got 2 or 3 fully active drugs. Fully active drugs based off those resistance tests, because that's the best path forward for the patient to get to undetectable. And we have to remember that for some of those patients, even these newer modern regimens are going to fail. And so sometimes we have to look for clinical trials. We have to find a new drug and a new mechanism of action, something that they haven't taken before, something their virus hasn't seen, in order to give them the best chance to get to undetectable. Clinicaltrials.gov, there's a lot of trials that are happening. We actually have a trial here looking at heavily treated patients and trying to track characteristics. And I'm not sure, are you familiar with the PROMISE trial?
Yes, the files.
Uh-huh.
Yeah, so we had 2 groups here, Palm Tree and then Bios Clinical, and they both do a lot of these studies, so we're really fortunate to have 2 options.
I love it, because everybody watches Palm Springs. This community is different. All right. Evolution of treatment. We've come a long way. 1987, all we had was AZT, and we found out quickly AZT monotherapy did not work. But it took us till the mid-90s where we got to a combination where we actually could control the virus. That's when we got combination therapy with protease inhibitors and nukes, and we took 3 different medications, often 18 or 20 pills, 3 times a day. But it wasn't until 2006 when they figured out how to take 3 medications and put them in 1 pill. When we got to a single tablet regimen with 3 drugs in 1 single tablet. That was a triplo. And then 2018, we finally got to where we had regimens that were not daily pills. 2018, the first long-acting drug came out. It's every 2-week infusion. But shortly after that, we got injections that were every couple months. December last year, we got an injection that's every 6 months. It's being studied with another long-acting drug. The options are there. We're going to get away from pills, or we're at least going to have the option. Some folks don't want to get away from pills. They hate the idea of shots. My philosophy is make it a conversation with your doctor. Talk about what's best for you, what suits your life. Because let's face it, the older we get, we know we're not getting away from pills. I take pills for my diabetes. I take pills for my cholesterol. I take pills for my blood pressure. Losing a daily pill for HIV isn't going to change a whole lot. All right. Back to ending the epidemic. Diagnose everybody as soon as possible. Rapid start, get everybody on treatment, get them effectively undetectable, get them controlled, durably suppressed, prevent new transmission, syringe exchange services, PEP, PrEP, whatever we need to do. But y'all think about it, if everybody's undetectable, we don't need those. And then respond to outbreaks so that things like Scott County, Indiana don't happen where they have an outbreak and they don't have the necessary tools and resources to address an outbreak of 47 new cases of HIV. We do all this, a 75% reduction in new infections in 5 years, 90% reduction in 10. But thinking about what we could do today, thinking about 87% undetectable, if we just address those patients that are not undetectable and do what we can to get them undetectable, moving that needle, thinking about those 90,000 patients, the 12,000 with multi-drug resistant virus, we've got resources. We've got medications, we've got clinical trials. We just have to identify them. We have to connect them to the proper services. We created an educational website called HIVandresistance.com. On this website, we have a discussion guide that helps facilitate a conversation with a patient and their doctor. It just asks simple questions. Come here. Maybe he just wants me to give it a little more love. It just asks some really simple questions. Just basically, do you know when your last labs were? Were you undetectable? What was your viral load and CD4 count? Basic questions that we hope we would all know, but not everybody does, and not everybody's comfortable having this conversation. Some patients go in, the doctor tells them you're undetectable, your T cell count's 685. Okay, they're nice questions. No conversation. We also ask, you having challenges taking your medication? And we ask, are you taking it like you're supposed to? So we're looking for any kind of tolerability, side effects, any kind of struggle there for adherence.
How's that?
You like that better? All right. And then we ask a couple other questions. So we look for patients who struggle with adherence. We look for patients who struggle with side effects. We also ask, if you changed medications in the past, do you know why? Resistance related, to uncover a resistance we may not know about. Sometimes our current doctors don't have all of our charts, all of our records from previous offices. So good information for us to share. And then lastly, we ask about any other conditions, anything else the doctor should be aware of, mental health conditions, COVID, Hep C, substance abuse, anything that the doctor might want to know that may uncover any kind of adherence related issues. That document is available there at HIVandresistance.com. There's a very basic HIV 101 presentation there and a companion resource. And it's also available in Spanish. All right, almost done. At the end of the day, remember, our medications, multiple targets. The medications target different steps in that virus in order to get us undetectable. Because when virus copies itself, it can mutate, it changes itself. Those mutations cause resistance. Medications fail. We can overcome that resistance by changing medications, changing our regimen. But the goal, no matter where we are, whether we're treatment experienced, heavily treatment experienced, whatever regimen you're on, the guidelines and the goal is always to get us back to undetectable. All right. And you can find the Thera community team on Facebook. You can like us and follow us there.
Thank you very much. Any questions? Go ahead.
When I was first diagnosed, I got converted for 14 months. And finally, after a year, I said to my doctor, I said, I can't go undetectable. And he said, I need to take the genome archive test. And what's funny is in the 14th month, when I took the genome test, I converted. But basically, what I'm having problems with right now is vitamin resistance. And most of that's magnesium, calcium, or zinc. And I've even had 2 doctors say, oh, that shouldn't affect you, it shouldn't affect you. But it did. I've fallen out 3 times now because of magnesium, I believe. I was taking a multivitamin that was too close to my HIV meds. So now what I'm doing right now is I've gone to try to find some liquid vitamins like vitamin D and vitamin B complex, and I'm going to try to find an iron one. But you'd be surprised how many things have magnesium in it. And so what I'm doing now is I'm taking my HIV meds at night, trying to allow myself at least a 4-hour window. But I don't get my next test until November. What I wanted to ask you about was the 3 new drugs, or the drugs that we're talking about. Are they like assisted drugs? Are they independent drugs? Or how do they correlate with someone who is resistant? Non-resistant.
So 3 drugs in 3 different classes. Fostemsavir or Rukobia is a tablet. It's twice a day. And Trogarzo is an infusion every 2 weeks. It's a monoclonal antibody. And then lastly is Lenacapavir, which is Sunlenca, which is a capsid inhibitor, and that's every 6 months. So even in thinking about that, there's the potential that for 2 fully active drugs, we could be on long-acting drugs. We could be on something every 6 months and an infusion every 2 weeks, and maybe avoid the pills or greatly reduce the number of pills. It's an option. It's a possibility. And I think even thinking about what's in the trials, some of these new antibodies that are being studied, some of them are every few weeks, some of them are every 6 months. The future will be completely different.
Yeah, you mentioned the supplements, and then a lot of the supplements we take are for GERD and gastric reflux and stuff. So anything with calcium, magnesium, any antacids, some drugs like Ropipride or Endurance, you can't take those together. So it's just, you've got to look at everything. Ask your doctor, ask your pharmacist. Your doctors are busy. It's hard to get everything in, a 15-minute appointment. But you can always make an appointment every time you go in, and you get that package with that list of things you throw away. You can say, well, I'd like to ask the pharmacist a few questions, and they'll always make the time to do that. So it's always good to ask about, because your supplements may not end up in your med list. They're supposed to do it, but it doesn't always. So it's really important to ask those questions and make sure it's in there so they can monitor for those, because it's not enough.
Do y'all keep a list of drugs in your pocket, in your wallet, including your vitamins and your supplements? In the phone? I'm old like the baby Jesus. I still write stuff down.
Hi there, fellow Texan. I have a couple of questions. This past year and a half, I've become anemic, and I just got declined yesterday for a hematologist from Desert Oasis here, and also recently, or also during that time, my vitamin D levels are in the thousands or something. So for me, I've stopped taking any vitamins, and I'm just curious about those situations. And at the very beginning, when I walked in, I thought you said something about weight, which hasn't been discovered or discussed. And I know that medication HIV in different areas. And is there a certain area that's better than the other areas in stopping the replication process? I know that's a lot, but thank you so much.
All right, let's recap that. That was a lot. Um, I think first, in thinking about the weight gain, that's the easiest one to address. Everybody's going to respond different. There are some people who don't ever gain any weight from the medications, and there are others who gain 30 pounds their first year. And then within that 30 pounds that they may gain, it's whether it's subcutaneous fat or whether it's visceral fat. And that's different because the visceral fat has other health problems. So it's an individual thing, but it's something that I think we have to track. I literally just saw an article this week that was talking about waist hip ratio has the highest indicator and predictor of mortality in people with HIV, just measuring the waist, more so than BMI or anything else. And so there's a reason that they measure the waist right at the belly button, and then they measure the hip at its widest point. The reason is they're trying to assess where you gain in the weight. Because if it's in your waist and it's up higher in the body, it's likely visceral, which is going to have all the metabolic health problems. If it's lower, waist to hip area itself, then it's likely subcutaneous. Then it's more likely just obesity. And diet and exercise will help that. No. Anemia. So that's a whole nother challenge. And I think it may depend on which medications, medication history. Anemia has always been a problem in HIV and with medications from day one. And I don't know that we've got solid evidence for exactly why. AZT was really bad about it.
And then there's one more question about resistance, I think you asked.
I just wanted to know with the HIV medications that are out and they attack the virus at different points in the city, is there a certain point that is proven better to attack than the other? It's like a three-prong kind of thing, but is it the replication that's the medications are more effective at stopping, or?
Ultimately, I think the entry inhibitor class would be the best. Just thinking about the fact that it stops the virus from actually doing any damage to the T cell. But I think the integrase inhibitor class has shown to be the most durable and the strongest for us. That's why I'm anxious to see with these that are in trials with the antibodies to see how that pans out.
Mr. Osborne, I'm in that 1% group. I've been HIV positive since 1984. And I have been on the free therapy program for 6 months now. But I feel like I'm a guinea pig. My doctor said we're still trying to figure out what the program should be. So he's suggesting that I may not need to have Trogarzo infusions after I've been doing it for 6 months. I believe next week will be my last Trogarzo infusion for a while. Is there any thought on, how long you can stop it and when you have to restart it?
Well, that's a loaded question.
Well, and I am under attack. I have fortunately since taking Trogarzo and Sunlenca and Leucopia, I am no longer detectable. So for the first time in my life. So I'm grateful for that. But I'm just curious because I kind of feel like I don't know where we're going with this. And maybe my doctor doesn't seem to be necessarily sure of that either.
And I think first I'd want to ask questions like, which would you rather lose, the Rukobia or the Trogarzo?
I'd rather lose the Sunlenca.
The every 6 months, really?
Yeah, it's the most painful. It's like having 2 nasty bee stings for like several months. So
Interesting. I think that's part of the conversation, right? Is which one do you Would you rather, that sunliquor from what I understand is pretty strong and durable. The good news is with Trogarzo, if you didn't fail it, you can stop it and come back to it. It'll still work.
Right, that's, yeah, he's indicated that there's no resistance development to it, so we started.
So it could develop some resistance, but usually what happens is the molecule, the virus changes a little bit and the molecule becomes like 70% effective if you were failing it. So it doesn't completely wipe it out. But if you just stop it, you wouldn't develop resistance to it if you just take it away.
But to your guinea pig, comment, I mean, we're all guinea pigs, right?
Right.
Nobody
right.
knew what they were doing back in the eighties and the nineties. We've been guinea pigs the whole time, so it's just kind of a continuation of that. And
I guess I asked because it does seem like it's the end of the road. It's kind of like, okay, what happens next? Because, as far as I know, I don't know that there are any more medications beyond this, that could help me, so I'm hoping it continues. But, I'm also concerned about stopping Trogarzo because, I kind of feel like, stopping to do what, to wait to see what it does, and then when we have to go back again. It's kind of scary.
And I think that's the toughest part for us, right? Is it is scary. And everybody's virus is going to be unique. And what's going to work for you isn't what's going to work for me, isn't what's going to work for Jeff. So I think that's also part of the conversation. It's the right combination. I don't know what's right or wrong to stop the Trogarzo and see. The good news is if you'll be able to add it back in if your viral load comes back up.
one other important thing to remember is you as the patient have the ultimate decision. I mean, you're the one taking it, and if you're not comfortable with something, you can say that and say, I'd rather stay on. Than be cautious and conservative, and do that. And then to your question about what's next, there's the antibody, the monoclonal antibodies that Daniel was talking about. So was Jim, that are coming down the line. So those will be coming available, and some of them are already available in clinical trials. So, even if this doesn't work, they're always coming up with new things. So I wouldn't worry. But if what you're on is working, stick with it. And if you're comfortable with it and it's working for you, it's the most important thing.
Thank you.
I have 2 comments. First, I want to say that I've only been positive for 4 to 5 years. I joined the club late. I'm sorry. The virus flies through the air out here. You can even get it through fake sex. How I got it. So it's incredible. But my point is, I'm in a study at the palm tree for this abdominal adipose tissue, and I like to do these studies as much as I can. And I don't know what I want to say about that, but yes, it definitely has affected the antiviral. The next thing I want to say is I've been below 20 copies since I got on the medication. All of a sudden, it went up to 580. 2 weeks later, I demanded another test. Is it lab error or what? And it was in the 400s. So I said, I want another test in 2 weeks. It was 60. And then it dropped to 20. Nothing in my life had changed. So I'm really pissed off that I didn't record the lot of the antiviral I was taking and ask questions about that. Because if the drug was bad, that might have been the answer. I didn't have flu. Does anybody else have that same experience?
So I've been hearing that one of the practices, the labs were unreliable for a while. People were flipping like that, and then they stopped. So, and it's not necessarily the drug lot that you're taking. It might be the lot of the labs that you're taking, and those things can happen. So you are right to keep insisting to get retested and make sure to keep that down.
My God, I would think that it would affect a lot more people than just me. The lab. The lab core is functional. I mean, I can't.
Well, I think it actually could affect more people.
Yeah.
But whether or not they ask questions is a different story.
That happened to me. I've been positive for 19 years. Never, ever had a blood before. And then, you know, my CD4s and I pulled on 20 copies. But, what happens, but one day it was like 2,000 copies and it just like happened. And then I tested again and it was came down to 600 tests again. And it was as if nothing had happened. So it was a really bizarre flip, and it was in fact with the same exact lab each time.
Mhm.
So
And I've seen that. I had that same thing happen with the lab in my doctor's office. They kept showing I had a viral load. And finally, she said, "You know what? You're my guinea pig." She said, "Go across the street to Quest." She said, "Then come back and get the labs over here, and we're going to compare." Her lab had a problem.
These things happen. Anybody else have questions?
Had a change of medication recently, and I've noticed that I went from a little container filled with pills every day, now I'm down to about 4. So I've had this reduction of, prescription drugs. I had 5 years ago, when I started on the target, it had huge side effects for me, gastrointestinal and all kinds of issues. 125 is, I didn't get all these 125. But I also, have a drug issue and some other issues as well. And the adipose tissue is another thing that's another issue with the drugs. But what I wanted to ask was, even with the newer drugs, with the one pill, which I've been doing for, since they started, even those are too strong for me sometimes. And I have not told my pharmacist, but I mean, my T cell count's probably in like between 400 and 600, it fluctuates. But I've actually cut the pill in half and been taking half of the pill for the last 3 years. And I'm still under 25. And I'm still all in the running of the mistakes with it. Now, I know that's not ethical. I'm sure I couldn't be saying this out loud. But you know what? The drug is really strong and I'm super sensitive. So I found myself thinking like for me and my gastrointestinal issues started to go now. So I didn't need to have as much of the drug as other people maybe needed to get 125. But it works for me. And I know that that's not, I should probably not say that out loud.
I don't disagree with
All
you.
right, I'm just saying this, but personally, it's worked for me, and I'm really conscious of the fact that I get a blood work done every 3 months. Don't even include that, under 50 copies every 20 copies, and that my T cell count isn't coming down. It's pretty much stable between 350 and 400, which is kind of low for a T cell count. I'm okay with it, it's good.
I don't disagree. I'm a pharmacist, but I have always believed that I don't understand how it's possible that somebody 18 years old and 120 pounds is taking the same dose as somebody that's 50 years old and 300 pounds, knowing the volume of distribution and the metabolism. It isn't logical.
Yeah, I mean, I work with drug companies that are developing, and the idea is to come up, they don't want to have different drinks for everybody. It's really complicated for everybody's patients without a pharmacist. So they make a one size fits all. And one size fits all is not fit everybody's life. So yeah. And that's something, I mean, if it's not working for you, work with the doctor. It's better to tell them what you're doing instead of just doing it on your own. But if it works, it works. And people do it all the time. And I think it's better to make sure the doctors know they're doing it. So that way they can think, okay, it's working for this patient. Somebody else is having problems. That might be something to consider. Because, one size fits all.
I'm not brave enough to drop that dose in half. But I'm not mad that you did it.
Well, I also love to be, validated.
That's a guinea pig.
Yeah. I think it's for 30 years for HIV, so, I mean, you said that before, I thought the same thing out the open, but, I mean, I was diagnosed probably in the late nineties, 2005, somewhere around. I didn't go into places, I didn't. So, I mean, I get it, and I was part of that whole transition, where we weren't the first people who were dying, we were the second wave, they were active treatment. But even on the other side,
Mhm.
so I'm a proactive kind of guy, so for me, I have all these issues going on with all of it. You know, whether it was I didn't get the hump on my neck, but I got, I got a belly that I couldn't feel. So I got a couple of things that side effects from the earlier drugs. I thought at the gym, everything. It's not good. It is surgically something. So I get that. So I have to live with that and I have to be less than living about it. So,
Anybody else have questions or comments? If not, thank you, Jim. We appreciate you coming out all the way from Houston.
Thank you, Sarah.
Yeah, if you want to if you have any questions, so this will be posted online within the next week. And I copied of the PowerPoint as well, if you want the information. You know how to receive that as well. Thank you, we'll see you next month, and announcements, so that's coming up. The All Day Day event on December 1st, will be right here, and that'll be 4:30 in the afternoon, with big people, but in this building. And so that'll be the second annual, Timothy Ray Brown Symposium. We're going to place a star for him downtown on the stars, and fun of the now infamous AIDS sculpture, in the Memorial Sculpture location. That won't be up yet, so nobody dies will be offended by any of that, but that's where it's gonna be, hopefully they'll resolve that. And then we'll move here, and we'll have presentations from several peer researchers, some from the collaborator that we work with. You guys do NIH funded peer research, and then the city of Hope is gonna have a reason to talk about a trial that they are starting, really fascinating trial, but they're gonna be pretty patient for it. So I'm excited for that, and then tomorrow, City of Hope patient Paul Edmonds, one of the kind of safety benefits places, the poster boy of being cured. And so they're working together at this experiences. So thank you for that. Also, Mizell on November 15th is going to be doing an event on AIDS quilt. I'm not going to bring out the Betsy Ross AIDS quilt from San Francisco. Everybody knows about Lee Jones, but Kurt McMullen was the one that did all the stitching, really coordinated that. Was kind of the driving force behind it. So they've been, I've heard come down for their honor on what she did. And we're creating quotes for a number of people. If you want to create a book panel, go to their website, check it out, or reach out to me. And we'll give you the link for that. We are going to be doing panels for Timothy Ray Brown. So that'll be available, and it's also one for HIV. Next move is. Yeah, that's right, but we have